All right, it's 5 o'clock. I think we're going to go ahead and get started. Welcome, everybody. Thank you for thank you for coming. This is I think the first time we've tried to do one of these, so bear with us a little bit as we go through it. I'm Richard Month. I'm the president of the PSA. Our panelists, in addition to myself, are Gordon Morwood, who's our Vice President of Professional Affairs, Joe Galassi, who's our co-chair for our Committee on Governmental Affairs, Michael He, who's a member of our Board of Directors, and not on the list there because I wasn't sure if he was going to make it because he's on call, is Josh Adkins, who is also a member of our Board of Directors and a member of our Executive Committee. Just a couple housekeeping things real quick. I have everybody on mute right now. If you have a question you'd like to answer or you'd like to have us answer, let us know by using the Q&A tab on the bottom of your screen. Feel free to chat amongst yourselves in the chat screen. I can't guarantee you we're going to get to questions if you ask them on the chat screen, so please use the Q&A. And when we get to questions, if you have additional feedback, we'll ask you to use a hand raise just so that we can keep things as organized as possible. We're going to go through the questions first that we got from the registration page. I have a brief presentation here, hopefully not going to take any more than 10 or 15 minutes, and then we'll get to the Q&A. First things first, here's our patented disclaimer. Everything we discuss today, not medical or legal advice. We may be talking about things that are in direct contradiction of CDC guidance, will include off-label discussions of medications and equipment. Proceed at your own risk, and also our anything we talk about is not the official position of anybody other than the person saying it, not our employers, not the PSA, the ASA, or the Pennsylvania Medical Society. Now that is out of the way, Jen, next slide, please. We're going to go through some scientific stuff real quick. Next slide. This is the most recent data we have. We've gone from a little over 100 cases on the 19th to 479 as of yesterday. We've had a total of 2 deaths in the state, and as of midnight this morning, Philadelphia has overtaken Montgomery County as the county with the most confirmed cases. Next slide, please. There's a lot evolving about this disease. I just wanted to point out the outstanding resource that anesthesiology has put out. It's free to all right now, about what we've learned from Wuhan and elsewhere, intubation and ventilation strategies, techniques for preventing infection, perioperative implications. It's all available directly through the anesthesiology website, and right now it is free for all. Next slide. Basics, a lot of you know this already, but just to be complete, novel zoonotic coronavirus incubation time seems to be very variable. Primarily carried by respiratory droplets. Aerosolization is possible. It is very hardy on most hard surfaces, it can lasting several days, but it's readily killed by isopropyl alcohol, hydrogen peroxide, or sodium hypochlorite. So wash your hands or wipe surfaces down. Interestingly, while this was originally described as a lower respiratory infection, dry cough, fevers, myalgias, GI symptoms are starting to become more prominent. As a matter of fact, the index case in the United States was fever, nausea, and vomiting. And then, of course, we're worried about decompensation into ARDS, also associated with myocarditis, depressed EF, and lymphopenia. Next slide. These are the current guidelines, recommendations from the ASA and the CDC when intubating a patient with known or suspected COVID-19. All involved in the airway management should wear an N95 or PAPR device, eye protection, gloves, and gown. Should take place in a negative pressure room if at all possible, and you should be fit testing your masks. Interestingly enough, the APSF has a gentle recommendation that PAPR may be warranted for airway procedures because of their experience with SARS, which is SARS-CoV-1 virus now, while using N95 masks. After or before before intubation, you want to make sure that you have a HEPA filter protecting the oxygen bag to avoid aerosolizing into the room. Pre-oxygenation with 5 minutes of tidal volume respirations. RSI is the general recommendation for these patients to avoid awake fiber optic intubation and avoid positive pressure ventilation, both of which can aerosolize. The most experienced anesthesia professional present should perform the airway. Any suctioning should be through a closed system if at all possible. And if your initial intubation is unsuccessful, rather than using positive pressure ventilation, the recommendation is to place an LMA while shifting to a second technique. Next slide. Management strategies, I'm not going to spend a whole lot of time on this. Supportive, mostly ARDS symptoms and typical ARDS therapy. Pharmacologic therapy has been all over the news lately. The antiviral success has been mixed. Remdesivir is currently under trial. Lopinavir and ritonavir, which are HIV antiretrovirals, failed to improve outcomes. Favipiravir, say that 5 times fast, is seemingly successful in China, but those results are still unpublished. Chloroquine or hydroxychloroquine are kind of the new IT drug at the moment, based on a small French study that's out, but that it's a very small study. The data is weak. There's a second small French study that's with a combination of hydroxychloroquine and azithromycin. That also was promising, but again, that's a very small publication and it's actually pending still. Next slide. Experience out of New York is showing that C-sections may be pretty common in COVID-19 positive patients or patients under investigation. Society for Obstetric Anesthesia and Perinatology has released guidance and they are constantly updating it. It's been updated twice since it's been released. And in addition to the standard recommendations, the with COVID patients, the recommendations are early labor epidural to avoid having to do GA on these patients if at all possible, avoid having to intubate them. Everybody entering the labor and delivery room should wear a face shield, face mask, gown, and gloves. Avoid emergency cesarean delivery when at all possible. The guidelines, again, if at all possible for C-section, are ideally that all involved wear N95s at the start of the case. The reasoning behind that is that these can devolve to intubation very quickly and there's not going to be time to don an N95 or a PAPR in an emergency scenario. If the intubation is required, everybody in the OR should be wearing airborne PPE at the time of intubation. Some places are handling this by putting everybody in N95. Some places are handling this by having anybody who's not intubating the patient leave momentarily, and then extubate either in the OR or in a negative pressure room. Next slide. I have a number of resources listed here. We're going to be posting this presentation on the PSA website soon after this, so these resources will be available to you. Next slide, please. All right, so now we're going to go through some equipment, logistics, and practice management items. We've been getting numerous questions on this. Talk a little bit about PPE. At this point, I hope everyone's aware of the PAPR device and probably becoming very friendly with it. These can be reused and disinfected with a single wipe, although I warn you that some hospitals have very involved cleaning protocols for these, so do what your institution tells you to do. Next slide, please. N95 masks filter 95% of airborne particles, should be used for aerosolizing procedures. Preference should be given to anybody who's doing an aerosolizing procedure, anybody who's at high risk of severe illness, or anybody who's within 3 feet of the airway in a COVID-positive patient. They are CDC and FDA approved for 8 hours of extended use, and when trying to extend use, they can be donned and doffed up to 5 times with proper hand hygiene techniques. We're recommending you consider wearing a face mask over the N95 if you can. Again, supplies with supply constraints as they are. However, the current CDC recommendation is to discard masks after working with patients under contact precautions or following aerosolizing procedures. So with that, I have one more disclaimer. Now we're getting into the point of how do we extend supplies? What can we do in lieu of CDC or FDA guidance? A lot of this is now going to be off-label, contrary to explicit CDC guidance. Next slide. So a couple of different ways that has been talked about for cleaning surgical N95 masks for reuse. The primary concern with these masks is fomites on the surface. Anything that enters the mask fibers gets caught in there. It's extremely unlikely to disassociate. So what you're really dealing with is the surfaces. And it is probably most likely that people who get this disease will primarily get it not from airborne or aerosolized spread, but from contacting surfaces where this is living. The two primary techniques that we've been that we've heard about for cleaning these is using cleaning wipes, bleach wipe or hydrogen peroxide to make the surface damp but not saturated, and then placing it in a porous container, usually one of those brown paper lunch bags, to dry completely prior to reuse. You shouldn't be sharing masks. They should be single user only. UV light, there are several techniques out there. I actually just had University of Nebraska has a very thorough technique on using basically the OR UV cleansing lights to reuse their masks. The primary concern, in addition to spreading fomites, is the breakdown of the elastic straps and making sure that the fit remains. There is a paper here for a resource on using the using UV light to clean N95 masks. Again, this presentation will be available, and I'll also post the University of Nebraska document if I can. Next slide, please. With the bill that was just signed into law on Wednesday, the Families First Coronavirus Response Act, included a blanket waiver of liability to industrial respirator makers so that they can market and market to the healthcare sector. So you're going to be hearing a lot more about these industrial respirators with a number of alphabet soup to be used in the medical market. The only difference between these and the surgical masks is that they are not cleared as surgical masks. You would theoretically have to cover this with a surgical mask when used, but again, that's all going to depend on supply constraints. But they meet the same NIOSH standards. The N95 industrial mask meets the same NIOSH standard as the N95 surgical mask. They both provide the user with the same amount of protection. The N, the R, and the P are just whether they are their efficiency at stopping oil-based solvents. That's not going to be an issue in the OR. The only place that comes into play is that if you have a P95 as opposed to an N95, the use limitation is only as long as you can breathe through it. 3M actually recommends that you discard them after 40 hours of use or after 30 days, whichever comes first. But the only limitation on reuse there would be being able to continue breathing through the respirator. Next slide, please. The other option we have is to, as supply constraints subside in other countries, most notably China, who's slowly and rapidly starting to have an oversupply of some masks, you may be able to get these from other countries with standards that are equivalent to or similar to the N95 standard. Here they are. It's on the CDC website under alternate strategies on respirators. Know that these standards are as good or better than the N95. Next slide. Ventilators and anesthesia machines. We should be using heat moisture exchangers with a viral filtering rate of 99.99% at the Y connector. We need to make sure that the sample line is behind the HME filter so that its contamination is prevented. The recommendation is whenever possible that there also be a second HME or HEPA filter on the expiratory limb in case the first filter is soiled, or for backup. That lifts the number of particles that get through from 1 in 10 to the 4th to 1 in 10 to the 8th. And mechanical filters are recommended over electrostatic filters. Draeger is still recommending a 28-day decontamination period if a machine should become contaminated. So we need to make sure that we have at least some filters whenever possible. The number of filters you use and whether you use 2 filters or not is going to vary on the number of people in your the number of cases in your neck of the woods and your supplies. We're probably going to be more likely to use 2 filters in Philadelphia, where there are rapidly increasing cases, than in a place like Center County that has 1 documented case. Next slide. This is that filter configuration with the 2 filters set up. Next slide. Neither Draeger or GE is going to recommend that their anesthesia machines be used in lieu of an ICU ventilator. That being said, there are some things to recommend, or they have given us a couple of caveats that if this should happen, to keep an eye on. You need to make sure that you have enough flow rate going through the ventilator to make sure that you're not going to have condensation inside the machine. You need to make sure that anesthesia staff are cross-trained on ICU ventilators, and that ICU staff are cross-trained on the anesthesia machines. And you need to make sure that your scavenging systems are plugged in and suctioning appropriately, or you're going to vent exhaust gas into the room and probably aerosolize. Next, please. There may come a time when a lot of us are cross-covering in the ICU that haven't done ICU in a really long time. That's going to include anesthesiologists, CRNAs, especially those that have been ICU nurses in the past. The ICUs are going to get very busy very fast. For this, SCCM, Society for Critical Care Medicine, actually has a great series of videos on basically updating us on ICU care for these patients. And that's through the SCCM website, and that's free to all at the moment. Next slide. Handful of things here. I know in addition to the medical supplies and the safety supplies, we're also worried about keeping the practices afloat during this period of time. A number of different strategies here. Financial assistance from the hospitals. Some practices are asking hospitals if they can temporarily hire the CRNAs and bring them onto hospital staffs. Using PTO, cutting salaries where you have to, furloughing employees so they can continue to get benefits, although you need to balance that with their ability to get unemployment benefits if that's necessary. And then tax deductions are available for paid leave and paid medical leave and paid family leave. Next slide. The state of Pennsylvania actually has a number of business loan opportunities, either from the state or through the Small Business Administration. Since we declared a disaster in Pennsylvania, all of this is available. Pennsylvania Industrial Development Authority provides small business loans for, with no payments for up to a year, and Small Business Administration through the Economic Injury Disaster Loan Program can provide low interest loans to small businesses that can be stretched out over an extensive period of time. Next slide. Jen, next slide. Thanks. For personal finances, this is kind of in a state of flux because it really just happened on Friday, and the servicers don't quite know what to do with it just yet, but loans owned by the federal government, which is all direct loans, which are the loans that have been originated since 2010, and some FFELP loans, which are the older Stafford loans, have been ordered to offer forbearance of 90 days with no interest accrual and without jeopardizing the loan repayment plans, such as the Public Health Loan Forgiveness Program and things of that nature. The interest reduction is automatic on these federally owned loans, but the forbearance isn't. So you need to check with your loan servicer's website. I know for a fact my servicer does not have any information on this just yet because it came out Friday afternoon, but check back earlier in the week. This doesn't apply to loans that aren't owned by the federal government, but everybody seems to be willing to work with us on this at the moment. As for home costs, the Pennsylvania Supreme Court has halted all eviction and foreclosure actions through the disaster declaration, so none of that's going to happen. And the governor's office is still recommending you contact your lender or servicer if there are issues with being able to pay your mortgage. And with that, we're going to move to our question and answer phase. So I'm going to go through the questions that we got through the website first, and then we'll go through. I have a handful here on the Q&A screen. So the first one I have here is, what are the best practice recommendations for assigning anesthesia personnel who have risk factors for severe illness or death, age, or comorbidities to patients with known or suspected to have COVID-19? These are available through the CDC website. I know some practices have actually put together a risk stratification protocol. I have one from one of our former former members of our board of directors, who's now down in West Virginia, that actually assigns a point system to for different criteria. And he has actually told us that we could share that, so we're going to put that up on the website as soon as we can. Is anybody else on the panel have any feedback or any anything from their institutions on how they're implementing this?
Rich, this is Gordon Morwood. So, we have approached it from the standpoint of when we have assignments that we know are going to be relatively high risk, we sort of triage them based on individual risk factors. So we have a ward service right now that's starting to care for COVID-19 patients on an inpatient basis, where anesthesiologists have volunteered for that. And obviously we're trying to divert people from that service who would be at high risk and then have direct contact with patients. And the same thing with our ICU staff. We're trying to emphasize those ICU staff who have low risk factors to go into the ICUs. I mean, the good news is, I think for our faculty and our is that ability to divert patients to those who don't have risk factors. In other words, those individuals who are not at high risk can be diverted to those tasks where the patients are going to be concentrated. Most of them are not going to be popping up in our operating rooms.
Rich, hey, it's Joe Galassi. In Allentown and Lehigh Valley, we have significantly scaled back elective surgeries to the point where we're probably not going to need everybody on every given day. We have already asked physicians to self-identify if they have pre-existing health conditions, and those docs will have first preference for taking time off, whether it's paid or without pay. And we also have docs that want to continue to work. So for us, it's going to be just a matter of seeing how many docs we need any particular day. And it's going to be kind of a day by day thing, I think, at this point, because it's still pretty early.
Yeah, I know in our department, we've had a couple of people go out on leaves of absence because of known issues with immunocompromise or things of that nature. But it's going to be an evolving process as this goes through, and the number of faculty we have available to us changes.
The other thing is that if you're at a small practice, you may not be able to designate a intubating team. You may have to train everybody on the proper use of PPE, PAPRs, and things like that. You may not have the luxury of having 4 or 5 docs, 4 or 5 CRNAs to be on the intubating team. So certainly you should watch out for who is at risk of having severe illness if they do become infected, such as patients who are immunocompromised, elderly, pregnant people should probably not be on the team. It seems to hit those patients who have hypertension and diabetes especially hard. A lot of those patients could be taking ACE inhibitors. We know that ACE inhibitors cause upregulation of the ACE2 receptor, and that's exactly where the hook or the spike of this virus binds to, is it binds to the ACE2 receptor. So those people should be especially cautious when taking care of COVID-19 patients.
Real briefly, just one of the questions that popped up in the chat window was about when talking about comorbidities, was talking about pregnant healthcare providers. And I can tell you that this is going to be a fight amongst different organizations as to what the recommendations are going to be. CDC says that pregnant patients are very likely at elevated risk because of or is very likely to be at elevated risk because of immunocompromise associated with pregnancy. I can tell you that ACOG is pushing back on that, saying that the data, and they're right, the data has not shown any increased infection risk to patients or to pregnant patients. My recommendation to anybody who is pregnant and dealing with this is to probably to tread lightly. And I know the one protocol that I'm going to be posting that we'll be posting on our website, the one from West Virginia, has an automatic opt out for pregnant healthcare workers, but I don't know. But again, that may also depend on your staffing model. All right, the next question I have here is, are efforts being implemented to bring older ventilators, which have recently been placed in storage by hospitals or businesses, back to working condition in case of need? And I'm going to throw this one to Gord.
Yeah, so now I can only speak to you from our experience at Temple. I can tell you that our hospital administration has, for the past week, been beating the bushes and trying to find any working ventilator home ventilating support companies to see if they have rentals. I'm sorry if my connection is breaking up. I'm getting messages every now and then that my internet connection is unstable. We're also looking, we have a number of anesthesia machines and ventilators in our animal research labs that we're looking at removing and cleaning and then putting into service. Obviously not as a first line option, but I think the answer to the question is yes, if there's a ventilator anywhere at any point that was serviceable and could possibly be put back into use, now is the time to start looking at it, to find out if it still works, to find out if you can clean it, and find the disposable connections that you need for it. Because at the end of the day, if it's the option between that ventilator and no ventilator, everybody would much rather have those ventilators working. And I don't think any institution is going to be criticized for using one of these machines, provided that they've put their due diligence into making sure that it's serviceable and safe at the time that they.
Great. Anything else from the rest of the panel? All right. Next question I have is, are the personal protective suits that orthopedic surgeons use for total joint arthroplasties the same as or as effective as PAPRs in providing protection against COVID-19? No. They let in pretty large particles actually, and they may actually be more problematic in certain ways because stale air is definitely worse than moving air. So if you are using one of those full spaceman helmets that the orthos use for joints, you still need to wear an N95 underneath it. They do probably provide very good face protection though, so I'm not saying don't use them. I am saying that you do need to use an N95 underneath it. We talked about this a little bit during the presentation. ASA has recommended 2 bacterial or viral filters per general anesthetic. As a hospital that has a limited number of filters such that we cannot adhere to this, do you have any suggestions? I'm going to throw this to Mike.
So thanks. Yeah, the Anesthesia Patient Safety Foundation has recommended in an ideal situation that we employ the use of 2 viral filters. HMEF, heat and moisture exchange filter with a viral filtration efficiency of greater than 99.99% at the Y connector, and a second filter, another HMEF or HEPA filter along the expiratory limb right before you go into the machine. And the reason for this is that if the first filter, the Y connector filter, gets soiled, you have a backup filter in place. Each filter should have ideally a viral filtration efficiency of greater than 99.99%. So basically lets in 1 times 10 to the 4 particles. And if you double that with a second filter, you basically increase that to now letting in only 1 times 10 to the 8th particles. And these HEPA filters can filter down to 0.3 microns. The problem with not having a filter is that the machine can get contaminated. And once the machine gets contaminated, per certain manufacturers, for example, Draeger, the machine has to be taken out of service for 28 days, wrapped in plastic, and then taken apart and completely disinfected. So now you not only lose the anesthesia machine, but you could potentially lose a ventilator as well. If you have a limited number of filters, the preference is to have the filter at the Y connector and to connect your sampled gases on the machine side of that filter so that any gases going through that into the machine is now no longer contaminated, because the gas chromatograph can actually push the gases out to the atmosphere and aerosolize it. If you connect it on the patient side, if you did not use a filter, then the whole thing is contaminated, and then it needs to be scavenged. You also have to look at where you are in your patient population. Here in Southeast Pennsylvania, where we're basically surrounded by COVID-19 patients, we should be using 2 filters on every single patient for the general anesthetics. However, if you are in a county where you have no cases or 1 case, and you have a limited supply of filters, you really have to think hard and fast before you use a filter on everybody, and think about whether or not this patient is high risk or if they're showing any kind of symptoms.
Great. Thanks, Mike. The next question I have here is, how should we protect ourselves when giving anesthesia for EGDs or ERCPs? Should we intubate or not? What protective gear is recommended while giving anesthesia to these procedures? I can only tell you kind of our experience as it goes on. I don't know if there's I don't know if there's any really good, solid, best practices or recommendations. But I can tell you our practice at my hospital has been to intubate the inpatient EGDs where we would normally have done them under MAC before. We typically intubate our ERCPs on the inpatient side, and we've stopped doing outpatient endoscopy as of last week. Any other feedback from the panel?
Rich, hey, it's Joe Galassi. We've adopted a very similar protocol at Lehigh Valley.
So all COVID-19 positive patients or suspected positive patients, if they need to have EGD, RCP done, should ideally be done in an isolated negative pressure room. If you're performing that procedure on somebody who doesn't necessarily have any symptoms, their ASA does recommend potentially the use of a palm mask or a procedural oxygenation mask. It's basically a face mask with a reservoir and a perforation in there that allows the endoscope to pass through and could provide some level of protection against aerosolization.
Great. All right. Next question has to do with our one of the favorite topics that has come up, elective procedures. Where does PSA stand on elective procedures, and kind of where does the whole thing stand at this point? So the PSA came out as soon as there was a statement to get behind. We publicly endorsed the statement, so we've endorsed the ASA, APSF, CDC, CMS, and the Surgeon General. The CMS guidance was actually stronger than the ACS guidance that came out in postponing all elective or non-essential cases that can be postponed. It was kind of buried in the paperwork, but Wolf's order closing non-essential businesses did include an order against elective procedures in all locations, offices, ASCs, hospitals. All elective procedures are considered non-essential and would be against this order. Enforcement actions for the enforcement actions against that for people not following that that order will start at 12:01 tomorrow morning. So it'll be interesting to see what comes of those places that are still doing elective cases. And we will be following with the DOH and the governor's office, because it is our stance that yes, we really, we should be not whether it be for community spread or the absence of PPE in a lot of places, we are definitely of the with the ASA and CMS and the Surgeon General that we should be minimizing or eliminating non-essential cases as much as possible. There was another statement in this question about public statement on PPE. We obviously want there to be PPE. We're obviously going to do everything we can to get PPE where we need it. And I know that on the ground we're working, the hospitals are working real hard to get what we need, what we need to do to get the PPE that we need, whether that be through reuse programs or cleaning programs or attempting to purchase from overseas where we can. I know there are a lot of different strategies underway. Let's see, the next one I have is, do you have any statewide registration information of COVID-19 infections amongst anesthesiologists and critical care medicine MDs? It's important to know the incidence and clinical conditions, including PPD usage or possible transmission situations. I can tell you that all of the healthcare institutions and the Department of Health are being extremely careful with the identities of the patients that have tested positive for COVID-19 to avoid any HIPAA issues and to maintain their privacy as much as possible. You've got to understand it's rough on the individual patients as well. We can follow up with the DOH does have a lot of this information, and we can follow up with them to see if there are any kind of patterns or anything that we need to pay attention to. And then the next question I have is about benzalkonium chloride. which is the active ingredient in a lot of alcohol-free hand sanitizers. Are hand wipes containing benzalkonium chloride effective in killing the COVID-19 virus? For the data we have on SARS, it appears that using a solution and soaking in benzalkonium chloride would be sufficient on equipment and hard surfaces. However, hand wipes and alcohol-free sanitizers have actually been shown to not be as effective as alcohol-based hand sanitizers in killing COVID-19. So we should be using, if we're not washing our hands, we should be using an alcohol-based hand sanitizer with at least 60% ethyl or isopropyl alcohol content.
And Rich, hydrogen peroxide will also work as well. Hydrogen
Yes.
peroxide, hydrogen peroxide works to kill rhinoviruses after about 6 to 8 minutes. And we know that rhinoviruses are much hardier than coronaviruses. So the belief is that using hydrogen peroxide will also kill the coronavirus.
The number I heard on that, Mike, was 30 to 60 seconds of a 0.5% hydrogen peroxide or a 0.1% bleach solution is enough to kill this on hard surfaces. So they last a while on hard surfaces, but they are easy to kill with common cleaning supplies.
There is actually a study that was published in the New England Journal of Medicine that showed that the coronavirus can live for as long as 72 hours on plastic and steel surfaces, 24 hours on cardboard, and 4 hours on copper. So just be aware of that.
All right. The next question I have is, what protective gear are you using for nerve blocks? I don't do a ton of nerve blocks. Anybody else on the panel?
At Temple, for our routine patients, we haven't instituted any other precautions other than standard sterile technique for our non-COVID patients.
Agree. We haven't done anything different either for non-COVID or non-suspected COVID patients. If you are in a location that has a high COVID population, it's reasonable if you have the supplies that while you're performing a nerve block to wear a mask and also have your patients wear a mask.
All right. Next question I have is, with known or high-risk COVID patients, how are you performing intubations and are you using LMAs? I can tell you with patients under investigation or patients with known or suspected COVID, we are as much as possible adhering to the ASA and CDC guidelines, and we're really not using LMAs except as a life or death rescue device. As I said earlier, if we're intubating someone and our first attempt fails, rather than using the bag valve mask, we would put in an LMA to try to prevent additional aerosolization while we're waiting for or coming up with a backup plan or working on our backup plan. Any other feedback on that?
Yeah, this is Josh Atkins. Our ICU teams, with learnings from Italy, have been strongly recommending that you reduce flows as much as possible in the precursors to intubation. So if you're going to an emergent or urgent intubation, high flow nasal cannula is believed to potentially disperse the virus widely. Frequently, we're encountering going up to patients' rooms that are suspected for intubation. They don't have a mask on themselves, the patient. And so it really de-emphasizing non-invasive methods. And our teams are being instructed that you have a COVID suspected patient, if they're requiring 6 liters more of oxygen to maintain a SAT of 92 or higher, to move rapidly to intubation rather than try the standard efforts at non-invasive or high flow to prevent intubation.
Rich, I would just add one thing. I don't know if the question actually was referring to operating room anesthesia or not. This is something that we discussed on our team last week. And I think this is where, there's lots of guidelines out there. There's lots of information coming out and standards being put out by professional societies. Much like the rest of medicine, the individual practice requires some discretion on the part of the practitioner to figure out, like, what am I trying to achieve and what's the best way to get there under these circumstances. What's the best way to get there under these circumstances? And if you're actually providing an operating room anesthetic on somebody who just happens to be COVID positive, what we sort of reasoned through was, if this is a procedure that needs general anesthesia but doesn't need endotracheal anesthetic, of aerosolized particles and saliva, to simply use an LMA and remove it at the end of the case rather than try to intubate and extubate, if your plan is to extubate at the end of the case. So I don't know if the question actually referred to surgical anesthesia, but if that's sort of the question at hand, I would encourage people to think from first principles and try and figure out what you're trying to accomplish.
Agreed. And that actually dovetails into this next question, I think, a little bit. Given the fact that a small percentage of asymptomatic patients may in fact be COVID-19 positive, should we treat all patients as presumed COVID-19 positive in regards to intubation and extubation, regardless of the presence of symptoms? That would require to use a 95 mask for every intubation and extubation, not just those with suspected or proven COVID disease. I think this falls into areas of, what into risk mitigation and strategy here. If again, going back to the guidelines and the position papers from the different organizations, that was the initial position of the AANA when this started, was that basically all intubation should be done with N95 masks because of this high proportion of asymptomatic carriers. And at the end of the day, the question becomes, is that realistic? And I think we have to take into account that we need to balance the risk of what is the risk of actually infectious transmission from an asymptomatic carrier versus the volume of N95s that we have. I think you're more likely to get this from when working with someone who's an asymptomatic carrier, get this from a fomite and not cleaning surfaces or washing your hands than you are from an aerosolization from someone with a small viral load while taking standard precautions. I know Gord has feelings on this as well. If you want to chime in.
Okay. For those who don't get the joke, I've been railing about this for several days now. Yeah, I think when you look at the epidemiology of this disease around the world, what is obvious is that although everyone in our profession, rightly so, is worried about transmission, what becomes obvious is the vast majority of people who get this, and probably the vast majority of healthcare providers that get this disease, get it from droplet and contact transmission. So in other words, the patient coughs, they sneeze, they have viral loads on their clothing and their bedding. We touch those surfaces, we touch their face as we're manipulating their airway, and then we don't follow proper removal protocols for PPE, and we don't wash our hands properly, and eventually that virus finds its way into our mouth. So I know everybody's really fixated on the masks issue, and I don't discount that entirely, but I would say I've now spent a week working on the inpatient wards with patients who are known or suspected of COVID positive status, and I can tell you that as healthcare providers, we still have a long way to go to get down our appropriate PPE and hygiene practices. So hands, wash your damn hands, please. Because that's going to save you much more than any particular mask, probably.
Next questions I have are about MAC cases and ECTs. What are the recommendations for basically for mass cases for ECTs or MAC cases? I can tell you that we've been drifting away from doing MACs, just as I said in our for EGDs as well, and we don't routinely do ECTs in my institution. But does anybody else on the panel have anything to say about MAC cases or ECTs?
Sure, it's Joe Galassi. If I could chime in, I think if you consider what most practices are doing for MAC, which is really Big Mac, which could be considered a general anesthetic, and you end up putting an airway in to maintain the patient's airway. I think my personal feeling is you probably should get away from that practice. And if it's going to be a MAC, it should be a true MAC, where the patient is able to maintain their own airway, because the less you manipulate that airway, especially if it's a COVID suspect. I mean, if it's somebody that you don't think it's a low risk patient, I still think I would recommend that you try to keep them lighter than you would ordinarily. Make sure that surgeon knows how to give a good local. If there's any doubt, go with general anesthesia. And in regards to ECTs, we've had that long, hard discussion with our psychiatrists and kind of told them these are elective procedures and we need to hold off on them for now.
All right. Next question I have here is about intubating in the ORs. None of our ORs are negative pressure equipped. Should we be intubating in our PACU's negative pressure room and then transporting the patient down the hall, or intubating or intubating in the OR? I can tell you our practice in our institution is to intubate these patients in our ORs. What we lose in not having a negative pressure room, we gain from the rapid turnover of air supply in those rooms. We've chosen an OR for our COVID cases that is a little distant from the rest, and you have to go through 2 sets of doors to get there. We've made the decision to intubate in our ORs. Josh apparently had to jump off the phone call. As I said, he's on call tonight. But anybody else, Gordon or Mike or Joe, any experience there?
Yeah,
I can chime in on this one real quick, Gord, before you chime in. If somebody is already a COVID suspect and they're already in a negative pressure room, our decision, at least at this point, is to intubate them before we transport, whether it's coming from a medical ward or from the ICU.
Yeah, I would not disagree necessarily with that. We've sort of discussed in our own group whether or not, if patients are coming from an ICU environment where they are in a negative pressure room, whether or not we should intubate them there first, and whether or not we should extubate them. If we're going to extubate them, should we extubate them there at the end of the case? We decided to leave that up to the individual practitioners based on their assessment of the patient. If you're all worried about their airway or their hemodynamic status, that may not be the best idea, but if it's an otherwise straightforward patient, it's not enough. The question is, patients who are not coming from a negative pressure room, because most of our hospital rooms are not negative pressure rooms at Temple University. And so the question is, do you take a patient from an environment where they're not negative pressure, move them into a negative pressure room, intubate them, and then move them to the operating room? And I think this is where common sense overcomes, again, sort of the protocols and policies that are put out there. Both the CDC and the WHO recommend all aerosolizing procedures should be performed in a negative pressure room. Well, that's fair enough. And they decide that intubation is a potentially aerosolizing procedure. Well, that's fair enough. But if you're intubating somebody specifically for a surgical procedure and that's not going to take place in the negative pressure room, we decided that the risk benefit of transporting a patient around the hospital just to intubate them in a separate location and then bring them to the operating room did not actually add up. So we're not doing that.
All right. Let's see, what else do I have here? How long do we have? what are you guys doing about clothing in and out of the hospital? I know our department has always frowned on wearing scrubs in from the outside, but now has become very strongly opposed to any outside clothing being worn in patient care areas and vice versa. Any particular guidance from the other institutions on the panel?
Yeah, we absolutely require all of our staff to change into fresh scrubs when they come into the hospital and leave them there at the end of the day. That was even before this began. And for those of our staff who are now working in areas other than the operating room, we encourage them to do this.
Mike?
I think you have to look at the risk of exposure. I mean, how many different places in the hospital do you have to walk through before you get to your locker to change? If that is minimal, then the risk of exposure to the patients, I think, is pretty low. Either way, no matter if you're wearing street clothes in or you're wearing scrubs in, once you get to your locker, you need to put on new scrubs, and those scrubs needs to be changed before you go home.
We got a couple more minutes here. Let me see questions here. There was a question that came up. Would it be advisable to turn an OR to neutral pressure instead of positive pressure if you were going to intubate somebody in the OR? And I actually had this conversation with our physical plant folks with this very question, and our infection control folks, and they actually told me that neutral pressure is actually worse than positive pressure because of the air handling that would entail. You'd get less airflow, fewer room turnovers, and you'd end up with more virus around. So their recommendation was that if you can't make it negative pressure to keep it positive pressure, we actually don't have any ORs that we can switch to negative pressure because of the increased incidence of surgical site infections. So making an OR negative pressure is making the OR negative pressure is not an option. And I think for our last question, and I'll answer as many of these as I can on the Q&A by text, but I think is the last question here. Has anyone talked to anybody who either has COVID or has recovered? Do you, as someone who has cared for them, or they as someone who has recovered, have any wisdom for us?
So I have a friend who just was recently diagnosed with COVID-19. She lives in England. Very, very healthy, very fit, in her early 40s. She basically, the only issue she has is exercise-induced asthma. And she said basically it started off as a splitting headache one day, and rapidly progressed to fever about 103, 104. Her asthma flared up. She felt like she couldn't breathe. I mean, and she has no other medical issues, no other health problems. In England over there, that she calls 999, and they basically came to her apartment dressed in hazmat suits. Was eventually able to give her some nebulized albuterol and nebulized steroids, and basically told her that probably better to just stay at home rather than go to the hospital and risk further infections. But it basically lasted around 24 to 48 hours of those severe symptoms, to the point where she thought that she may not survive, and eventually did recover. So it not only affects the elderly, it not only affects infants, which have a high risk of morbidity, but it does affect the young population as well. So I would just tell everybody to, heed everybody's warnings and be careful.
All right. And I think on that note, we're right at 6 o'clock, and we're gonna have to wrap this up. I know there's still a number of questions out there. I'm gonna try to answer a few of them on the chat screen and in the next couple of minutes. We are going to be planning a second webinar, hopefully in about a week or so. Keep an eye out for that information. But I want to thank you for coming, and stay safe.
Thanks.